Good afternoon, everybody, and welcome to another episode of Muscat Endoscopy Academy Webinar Series. My name is Samar Alduri, and I'm Director of Gastroenterology at Medical City for Military and Security Services in Muscat, Oman. And it's my pleasure to welcome again my friend and co-faculty member from Muscat Endoscopy Academy, Dr. Morteza Shafazand from Karolinska University Hospital, Sweden, who's an expert in luminal endoscopy. And this is episode one out of a three episode series that we're going to be doing on uh, polyps in the GI tract, starting from their biology and physiology, going into the various resection methods from the simple stuff going up to the more complex things. So hopefully it's useful for people who are listening or watching. So Morteza, thank you again for being with us.
Thank you very much. Hi, everybody. And it's my great pleasure to be with you again, Summer, and a part of your fantastic job you're doing for endoscopy. Thank you for having me.
Okay, great. Thank you so much, Morteza. So I'm going to dive right into it. So we thought that today's episode is going to be about not about like the complex resection methods. That's very cool to talk about. But I think we need to talk about what we are actually seeing when we are scoping a patient in real time. So we're talking about polyps here, whether they're in the upper or lower GI tract. Most of the time, I think the vast majority of our chat is going to be focusing on colorectal polyps, their biology, location, morphology, and the risk that is associated with those, and the management strategy. So if I start with the first question here right away. So let's say that you are doing a screening on a patient and you see polyp on a regular Monday. What is your mental framework? What do you start thinking about? Do you start thinking about what the histology of this polyp might be? Do you look at location, morphology, or a combination of those? Walk me through your thought process, please.
Um, yeah, actually, the first thing that is when you see something that is not normal. So just stand up. Just don't be hurry. Don't think that, oh, I have to remove it now, right now. Just stay and think. What is that I'm seeing? And then in colorectal, we're talking about if it's a mucosal tumor or it's a submucosal tumor. Look at the pattern of the mucosa closely. Is it the regular glands you see? Something is pressing the mucosa up, which is, of course, a submucosal lesion, or it's coming from mucosa. Uh, it sounds very simple, but actually, I've seen people don't pay attention to that. And one example that we very easy may miss is a rectal small lesion that you think that, oh, there's another hyperplastic polyp, a little bit unusual. Give me the snare, and it's shown later on that is a neuroendocrine tumor, and if you are unlucky, it's not radically taken, and then you're gonna have some problem in the future. So look at
Mhm.
it and try to think strategically. Where am I? What part of colon am I finding this lesion? What is most common to find on this part? And is
Mm.
it and if we now concentrate on mucosal lesion, so is it neoplastic or is it non-neoplastic?
Mm.
Uh, do I think that I will find some dysplasia in this lesion, or no, it's not. And if it's not dysplastic, if it's not neoplastic, then depend also where in colon you are. I'm sure we're going to touch it more, and the size of the lesion. For instance, if I find a non-dysplastic lesion in the oral rectal part with the size of 3 millimeters, So,
Mm.
what is the commonly you can find there that almost everyone has? It's a hyperplastic
Mm.
lesion.
Yeah.
That then I don't care about it. I look at it that I
Mm.
that's not it's not maybe a miss of a neuroendocrine tumor, of course, but if I'm pretty sure that is a non-dysplastic lesion in the rectum smaller than 5 millimeters, then I don't need to
Mm.
take it. If the same
Mm.
lesion is in the right colon, so even it's a controversial as today's there are ongoing some studies says you can leave them, but by today the recommendation is even those lesions should take away. And I think that's because of our optimal diagnostic is not in that level overall in the world that we can
Mm.
for sure say that is not a neoplastic lesion. That's why
Mm.
ESGE or American guidelines, everyone recommend to take it away.
Mm.
So the
Mm.
location, where am I? What is the size of the lesion? What can I suppose? What can I accept having lesion in this part of colon or rectum?
Okay. And depending on that, you decide what to do next, whether to remove or biopsy or just send to endoscopic resection or surgery right away.
Yeah,
Yeah.
exactly, exactly.
Yeah. I fully agree with you on that. And really, I mean, theoretically, these things sound quite easy, but nevertheless, um, we have mm, we have colon cancer program screening program implemented in many parts of Europe, at least so far, but we still see a staggering rate of post colonoscopy colorectal cancer due to missed polyps or some small lesions that were not completely removed and so on. So this me into the next step. Like so, we have now this generation of trainees that is being trained with AI helping them as well to read polyps, which I think is a great technical aid. But if you were to explain to a trainee the typical appearance and location of an adenoma versus a serrated lesion versus a hyperplastic polyp, and of course, as you said, you should always slow down. Whenever you see something that doesn't look right, you should slow down. But where would you say you should slow down more?
Um,
Make you like, okay, you really
yeah,
need to slow down here.
yeah. I
As
mean,
far as
uh, when when you suspect something is there, so you have to make sure that you have seen the whole entire lesion. And I've seen many times that the colleague has seen part of the lesion and been very hurried to remove it, and then didn't pay attention to the rest of the lesion. And we have the different tools to help us to see the whole entire
mm,
lesion. Um, so that is very important. Make sure that you have seen the whole entire lesion. Uh,
mm,
One very simple is if you see that the colon is not very clean, that part is not so clean. So step on
mm,
the water pump, wash it, look at it, and change the position of the patient in that way
mm,
that you see the whole entire lesion in front of you. There is not lots of liquid, dirty liquid that disturbing you, etc. Unless you want to see it underwater, which is much better view you can get it, but you have to have a clear water. So again, slow down, look at it,
yeah.
and make sure. Look at it in the white light, look at it in the digital chromo, and sometimes if necessary, if you don't have like kind of the new generation of instrument, which is ESET instrument, okay, you may need have a regular chroma endoscopy as well to see the glands better. Slow
Mm.
down
Using the dye,
using
you
dye,
mean?
exactly.
Mm,
Uh, one of the type of lesion I'm more certainly thinking about when I'm saying that is the part that sessile serrated lesion, which has turned to dysplasia. And we know that the oncological path of sessile serrated lesion to turn into the cancer is completely different compared to the adenoma.
Mm,
It's going. I don't know all those things, but I think it's a BRAF, pathway, and it's
mm,
going much faster than KRAS pathway for adenoma. Um, so I see them. I removed a very small cancer in the right colon, which was a sessile serrated turning directly to this small cancer, but the colleague
mm,
saw only the sessile part. It was over the fold, small fold. He didn't look at the whole lesion very nicely, and then I had
mm,
to do a full thickness dissection on it
mm,
after corrective surgeon of MDT, etc. So look at it. If you suspect that it is a non-dysplastic lesion, then it could be a
mm.
hyperplastic lesion, but it also could be a sessile serrated lesion.
Yeah.
Yeah, hyperplastic lesion, as we know, they are much smaller. There are
Mm,
very rarely you can find some up to 1 centimeter or bigger. Then you have to think about again because sometimes adenoma you can miss, and we all have had it.
of
We
course.
send it to the pathologist, say this is a hyperplastic lesion. The answer coming, no, it's a low grade adenoma, low grade dysplasia
Mm,
adenoma. That's not a big deal because you remove it anyway, and that's why the
yeah.
guidelines say that you remove it. So because if it's a hyperplastic lesion, it's smaller. You can take it with a cold snare polypectomy, of course.
Mm,
But
mm,
if it's a sessile serrated lesion, that's why I'm saying so much that to distinguish if it is it sessile serrated lesion without dysplasia or with dysplasia, because the treatment is
mm,
completely different according to the new guidelines. Uh, no matter the size, if it's a sessile serrated lesion, it's 3 centimeter. You can't take it with the cold snare piecemeal bite by bite, piecemeal MR closely. But if you see the dysplastic area, then you have to go for hot snare polypectomy. So that's very important to have in mind when you look at the lesion, because think about this next step and prepare it for yourself. Very easy. Analyze it, and that's analyzing. It's what I want people learn during the intubation technique, during the colonoscopy. Be analytic endoscopist.
mm. Analytical. Yeah. Yeah. Exactly. I fully agree with you too. Uh, it's really important that these systems that have been put in place nowadays, they're not there just to make our lives difficult. They're there because they actually can change the whole uh,
Yeah,
chain of care for the patient. So it's definitely correct, and I think that kind of bedside or like on the scope assessment is one of these parts where uh, we still are struggling to train systematically, just because I think for trainees, most trainees, I think they struggle to get enough time on the scope in order to be able to develop these skills early on. Uh, it
I,
comes quite
I,
often slightly later on in training, I would say, because of just the sheer frustration of just wanting to be able to hold the scope and do things.
yeah,
So what do you think? Yeah.
yeah. And nowadays we have a very good tools to help us. We have a very good. First of all, if you have a very good intubation technique, that your CIT, cycle intubation rate time is not too long, then you have all the time to put and analyze the lesion. You have all
Mm,
the sophisticated instrument in your hand. You have
mm,
AI, probably a digital chromo, etc., etc. So you can get very long for optics diagnostic. I think it's
mm,
you have to find uh, you have to rely on your optic diagnostic much more than you rely on the biopsies. For me, a biopsy in colon,
mm.
except I mean, except IBD, etc. We were
Yeah,
talking about the lesion, it's only
yeah.
if I see the obvious cancer in NICE 3 or JNet 3, deep cancer, then I know there is no chance endoscopically at all. Then I take a biopsy and I tattoo it, and if it is place that I need to tattoo, and send it to surgeon. Otherwise, you rely on your optic diagnostic. It's very simple. If you if you want to find this is a dynamic thing. The whole changing of the lesion to more advanced, right? From low grade dysplasia to high grade dysplasia and early cancer. It's not like the
Mm,
whole lesion from that being no dysplastic at all. The next day is going to be cancer. You
mm,
have for sure some part that is a low grade dysplasia, but if you look at carefully, you can find high grade dysplasia in it, and sometimes
mm.
even invasive cancer or non invasive
Yeah,
cancer. So
yeah,
if you want to rely on your biopsy, then you have to have a very good optic diagnostic that to find that area to take a biopsy,
right,
right? And
right, right.
if you are that good to have that, if you have that good optic diagnosis, then you don't need
Mm,
to take a biopsy from that. Then then
yeah.
then make a good photo documentation or video documentation or whatever, and then discuss what the best option is for remove it.
Yeah, I think this is really good because I mean, um, talked about like cleaning the polyp, good distension, having a good angle, using the different modalities, and I think this is probably why AI still hasn't solved this for us so far. You have the latest now, like American Society of Gastroenterology. They have this thing that's called the living guideline, where basically guidelines are not something that is produced once every 4 or 5 years, but the guideline is being updated periodically every 3 to 6 months based on the newest evidence, so that it's a living guideline, so that
Yeah,
you don't have to wait, that you can implement the newest stuff as soon as possible. And as of the latest one that came out 2025, there was no recommendation for or against routine use of CAD-I and colonoscopy, uh, whether like it would improve, maybe it improves detection, but the long-term outcome impact is still uncertain. The fundamentals you're describing still matter, I think, enormously. Um, where do you think AI genuinely helps, and where do
uh,
you think it's being oversold?
I think per today, despite all those new AI system they are ongoing, per today AI has shown that for detection it might be helpful. Some studies say 10, 11%, some studies say a little bit more, but for assessment of the lesion, we still
Hmm.
have long way to go. And and
Right.
and it is also very simple. AI answer you whatever you put in there. Whatever you give the
Right.
AI, they give you answer, right? For
Mm.
me, it's like a biopsy. If you can show the AI the suspect area, then AI can answer
Yeah.
you. If you cannot find the
Mm.
suspect area and you show the low grade dysplasia part, then you get that answer back. So it's for me, it's a
Mm.
kind of the result of histology. Um,
Right.
what you give them, they can analyze that.
Yeah.
And I used to say my training. They say I said this is a it's just a thinking about that you have the whole lesion in front of you, uh,
Right.
and you have a dynamic. You can go forward, you can go backward, you can go to the right, to the left, you can go close to the lesion, you can put on the EDOF or near focus or whatever you have. You can digital color on it, you can chrome dye it, etc. Whatever you do, You can do
Mm,
whatever you want with the whole lesion. If you cannot make
mm,
assessment by that, how can the poor
mm.
pathologist gonna help you
Yeah,
and make assessment from a smallly 5-6 millimeters bite you give them?
right, right. And this is it's really good that you should say that, because I mean we need to keep in mind that when you're dealing with, especially if you're working in a unit where you're doing lots of resections, or you're taking many of these polyps, you need to have a good histopathologist as well, right? That can actually help you in improving the outcome of the resections that you're doing, because it's not like every unit has a gastrointestinal histopathologist. Many have just a general histopathologist. So I think it's really good to try and find out if there's one of those in your hospital, so that you can have a dialogue with them about how they want to get your polyps. How do they want? Do they want
Yeah,
them and then go in the formalin right away? Do you don't want them pinned on on a block on a cork board? Do you want them on a small like filter paper? How do you want them, colored with dye, before you
yeah,
see them?
yeah.
All of these things that can change a lot of that can change a lot of things. So um
Of course, and
it,
I add to that one. The difference is that because we have our distance to our pathologists in Western
mm,
country is not the same as in Japan, because in Japan the endoscopists do the pathology job as well. Look at it.
mm,
They learn how to cut the specimen,
mm,
and that's why what when you get surprised when you have find a tiny part like a 1 millimeter in an advanced lesion that you have been removed by EST or whatever you have done, but
mm,
still the report says that it's only a high grade dysplasia or it's a low grade dysplasia, because
yeah,
you have to be aware that how do the pathologists, how do they cut? They cut it
mm,
in Western
mm,
country each 2 millimeters.
yeah,
And
yeah, yeah,
I learned for some years ago when I did a EST, and it was a lesion where I suppose it was very very small, smaller than 2 millimeters in the part in center. Just when the nodulus went over to the lateral part, lateral spreading part, and we suspected, both me and my Japanese colleague, it might be a non-invasive cancer here, T1. And he learned
mm,
me. He said, "Don't send it just with the pin it up and send it." He said, "That area you suspect, put the needle with the other colors there, and ask pathologists to put a cut there as well. Then they want to see your T1 cancer."
I mean, this is great, and I wanted to scale back a little bit before we move forward to SSLs, or sessile serrated lesions,
Yes.
that we talked about slowly, because I think now we're talking. You said that like it's very important to differentiate like an SSL from an adenoma, and specifically because of the different biological behavior. Talked about the whether like an adenoma may have the KRAS or the APC mutation, while the BRAF mutation is like the
Yeah.
time from dysplasia to actual full-blown cancer is much shorter in SSLs that are dysplastic compared to the dysplastic adenoma.
Yeah. Yes, it is.
These, yeah, and now when we talk about SSLs, right?
Yes. All right.
SSL-related lesions. What I wanted to chat about a little bit. Um, You told us a little bit about them, and that you should think about whether you can remove them always with full snare, whether it's like in one piece or piecemeal, like in several pieces. And you should use a hot snare only if there is this plastic component there. But before we actually do that, we need to see them, right? And quite often, the biggest problem I think is that we don't see them as well. They're usually hiding
Mm,
in the right colon behind some folds, or like covered by a mucus cap, or they have this cloudy appearance.
mm.
So they're not really that visible, and they're quite flat and conspicuous lesions. So my question, I guess, here is, how would you approach trainee who's still who's good at technique right now, and we're getting into polypectomy, and you want them to reach these performance thresholds, which is, let's forget about the adenoma detection rate that is more than 35% according to the newest guidelines. Let's talk about the SSL detection rate, which should be what, 6-7% according to the latest guidelines, which
Yes.
I can imagine is going to be higher in the next update of this guideline. So how do you get a trainee to go from, let's say, 1 to 2% detection rate for SSLs to, let's say, that at least that 6-7% or even higher? What tools can you offer? Can we
Did you
offer a
see
trainee?
did you see a trainee who has a good intubation technique or no?
With intubation technique, they're done doing that part. Now they are getting into learning how to resect standard things, because we want to get them ready to start scoping patients as a part of a screening program, let's say. And you want to make sure that their detection rate of sessile lesions is acceptable. How would you help this trainee? What tools would you offer them? Like alluding towards, like, WASP criteria. How can we
Yes.
break them
Yeah.
down, for example, and all of these things that can make life easier for a trainee.
Yeah, and I suppose that the trainee is familiar with the WASP classification, and when
Hopefully,
hope,
hopefully.
hopefully, yeah. And as you said, it's maybe you wanted me to show the WASP or not?
Yeah, please show us the WASP, and talk us through it, and what your mental framework. I mean, you're an expert at this, so you can talk about this in your sleep. But what is your mental framework when it comes to SSL? Because I think quite often they're pretty
Okay,
difficult to
you
find. They're hiding.
yeah. Do you see my um,
Yes, I
okay.
see your screen. Yes, yeah.
Okay. Uh, then you see here, this is actually this is the VASP. That's when you look at the lesion, and you see that we call it part type 1 or type 2, if it's brown color or brown vessels or what you see. So as you mentioned, it's a cloudy surface. Um,
Mm,
and also I would say when you come to the right colon, and you let's see, you have the liquid at the medial part. So imagine you are in the cecum. You put the patient on the right side position to see the
mm,
cecum best, right? And all the
mm,
liquid go to the lateral side, which is opposite side of more normally, mostly opposite side of the valvula bahili. So when I
mm,
look at that area that is not liquid on, so the first thing I think with the white light, I see where can I say the mucus on the on this on the mucosa surface, uh,
mm,
which is opposite sides of the liquid, because all this liquid should be on the right side, the lateral side. Why is that part is mucus on the? Then I look at it more carefully, because we know that
mm,
serrated lesion, they produce lots of mucus, right?
mm.
So that's what I what
Right.
I what I look at it. The other thing actually with the white light you can look at with the big vessels you see in the colon. When you follow them, you see that some part they disappear, and then a couple of some 1 centimeter or 2 centimeter or some millimeter after, then you can continue that.
Right.
That start something in my brain. So why can I not follow that vessel very well? So I look more
Yeah.
carefully on it, because sometimes it's a serrated lesion disturbing that.
Yeah. Yeah.
Uh, yeah, and
And we're talking about right colon here specifically, or
yes,
the whole
yes.
colon, just
Now
for people who are listening.
No, because sessile serrated lesion, you find them right colon and also transverse colon as well. When you see that non-neoplastic lesion in the left colon, especially in sigmoid, either they are hyperplastic lesion mostly, or you can find if you those are much bigger that we call it traditional sessile adenoma, TSA.
Mm.
They have a shape.
Serrated, traditional serrated adenoma. You mean? Yeah.
Yes, yeah.
Yes,
So
yes, yes.
let's
Mm.
focus on the right colon because that's the important part of the colon, non-symptomatic
Mm.
part that can turn to a very cancer pretty quick. That's why recommendation of double checking colon. We have it in all kind of guidelines to make sure
Mm.
that you have seen the colon very proper.
Mm.
So the right colon, I put if I want to have at least 10 minutes for my withdrawal time, so I put
Mm.
2 extra minutes out always for
Mm.
right colon, much more on
Right.
right colon because
Mm.
there is a, yeah, everyone knows that left colon you may bleed, you can find them, etc., etc. They are not easy to find, to detect. And
Mm.
if your patient is unlucky, sessile serrated lesion can go to sessile serrated adenoma and then to cancer.
Right.
So when you look at it and the border are not very clear, you cannot with the white light, and sometimes even with the narrow banding imaging cannot see the borderline very quick, very nice.
Right.
And the shape is not like you see the regular adenoma. They are pretty regular, unless
Mm.
it had already turned to the cancer. But here you have an irregular shape, and
Right.
also those dark spots inside the crypt. But the other thing that you can distinguish between hyperplastic lesion and sessile serrated lesion is what we call lacy shoe. It's like yeah, you call it lacy shoe, right?
Mm.
Yeah, that
Yeah.
you
Mm.
see the vessel like that. All those things make me wake up more,
Yeah.
and I always think that they are not alone. If you find one, it's just a matter of to looking carefully. You find the second one as well.
Yeah.
So if the patient is pretty risky, or we have had sessile serrated lesion before that, etc., or a cancer history, I actually put either if I have an ESET instrument in my hand, I look at it with the head off, or with the narrow banding. But most of the cases, I just put the acetic acid on the whole right colon.
Right. To see them. Yeah. Yeah.
Yeah, and I have some
Mm.
pictures. If you wanted me to show it later on, I can show you how uh, you can see. Oh, the exactly size after acetic acid
Yeah.
color put it on it. So those are
Yeah.
basically what make my you know what make me to find them. And if they are small, it's not always easy to find. Is it a small cystic serrated lesion or it's hyperplastic lesion? It doesn't matter. In the right colon, you have to take it away. But if it's getting bigger, then you have to slow down again, look at the hole, make a color, put the acetic acid on it, make sure that you
Mm.
see the whole lesion in front of you, turn the
Mm.
patient's position if you need to see the hole, etc.,
Mm.
that you make sure that it's not a lesion turning to dysplasia, because
Yeah.
your choice of treatment is different then.
Mm. And in terms of like when you're looking at this, like for people who are listening, because uh, before using acetic acid or any of that, if you want to see these lesions, do you think they're better seen or visualized in white light or in MBI or BLI?
uh, Actually, it depends on what kind of instrument I have in my hand. uh, if I have a set instrument, And with those, and also my machine, actually the processor machine is X1. I'm talking about
Mm,
Olympus.
mm,
That you can use TXI model.
yeah.
Then it's helped you to for the texture of the lesion and the mucosa. Then you see something
Mm,
is there that is not normal.
yeah.
Get your attention a little bit more with the TXI.
Yeah.
So that's why all of my colonoscopy nowadays I'm doing with the TXI module on, always
Yeah. Yeah.
in
Yeah.
the
Mm,
colonoscopy, not gastroscopy, colonoscopy.
yeah.
And
Yeah.
yeah, and if it's ESET instrument, you can see it pretty much with the NBI because you have another chip, you see better, and if you get close to with the head off. But if I have an Xera 3, the older generation of Olympus, and if I have, let's see, a pediatric colonoscope only with H, which is high definition, not HQ.
Yeah. Yeah.
Then I don't
Then
then I don't trust that everything I see just with the white light.
you need to use MBI or
Yes,
some or acetic
in those
acid or something.
exactly in those cases with the patient with the low risk, I one time I look at the right colon is only with NBI.
Mm.
If the patient is with the if the patient with the high risk, I put the acetic acid and look at with the NBI.
Yeah, yeah, I fully agree with you there. I think people use different machines. So like if you're using Fuji, you can switch to LCI, which
Yes,
is
which is
that kind of
like a
reminds you of
TXI.
TXI.
Yes,
Yeah, yeah,
exactly.
yeah. And if you're using Pentax, you can use the eye scan and so on. So, and then on top of that, like, as you said, the intubation of the right colon, maybe do retroflexion, to see
Yes.
behind the folds. And I think from my practice, the most, without like, having to memorize WASP all the time, I think the most effective, efficient way for me personally to find SSLs and big numbers is usually just look for the mucus
Yeah.
and just think logically. If I have a fluid pooling on the left side of the screen, why do I still have mucus on the right side?
Yeah.
Uh, and then once you wash it a little bit, you see that something might be hiding there. So it really helps to just follow the mucus that way. But it really requires a patient that is clean, right? Because quite often what happens, I think, in real life is that you have many patients uh, that do not have a clean right colon. They might be clean everywhere else except the right colon, or maybe they are clean, but they did not drink enough water
Yeah.
to flush through the right colon. So by the time they come to the colonoscopy, uh, like this is a regular scenario, a patient is scheduled for colonoscopy, let's say at 9 a.m., but because of whatever delay, they're not scoped until like 11 or 12. And in the meantime, they're basically fasting. So whatever was left in the small intestine finds its way, that fluid that is mixed up with bile and whatever would find its way into the right colon, and I think that becomes a nightmare because trying to clean up this kind of sticky bile mixed fluid in the right colon takes a lot of time and really makes it difficult to find these sessile serrated lesions. So with these patients, usually, well, if I find like one or two of those, I just stop looking for more and
Yeah.
I
Yeah.
just reschedule the patient. Sometimes I bring them just the next day, so
Yeah.
that the
Yeah.
patient
Yeah.
is, if possible, just to get it over with, because I think you always find more, just like you said, you always find more
Yeah.
uh, once you start looking properly. So,
That, I
really,
completely agree with you, and also we know that by screening colorectal cancer screening, we are hopefully some data showing for those cohort we are decreasing the cancer incidence, but in the younger generation, which are not doing colonoscopy, 45 to 60, you know better than me that the latest data showed a very
Yeah.
scary result.
Very scary, scary, scary.
More than
Yes, absolutely.
300% increasing. And I
Yeah.
believe that they are SSL, that
Yeah.
they are sessile serrated lesion turn into cancer pretty fast. So
Yeah.
once we screen the patient, younger and younger generation of patients, which I hope Sweden also going to do that. So we have to know how to find them,
Yeah.
because if we
Yeah.
cannot find them, so the screening doesn't help at all.
Yeah. I
Uh,
remember. I remember. I remember one of our common colleagues that we used to work with. You had quite a funny remark, Dr. Pichel.
yeah,
He used to tell me. I find many SSLs, but unfortunately, I do not get any points for them because when you read, they do not count.
yeah,
Uh, and it's funny because it's really until recently, like this SSL detection rate was not really a thing.
no,
And even now, when it's being implemented, I think it's being implemented to quite modest
yeah,
6%.
yeah,
And six
yeah.
percent is too low. I think 15% is where we should be. Uh, but only the future will show. We just need more data there, and I think there's a lot of work that's going on in that field.
And we know that that I don't know if there is any data behind that, but my impression is that when AI miss some lesion, is mostly sessile serrated lesion they miss than adenoma. You have the AI on, you find the sessile serrated lesion, but it doesn't react at all until you get close to it or you put acetic acid on it, then it wakes up. So even AI, it's not as good, in my opinion, as good as normal adenoma for sessile serrated lesion, at least KI. I don't know. It's not a science behind that. It's my just only my my impression.
I mean, it was not trained on SSLs, right? I mean, the model initially was trained on adenomas only because adenoma detection rate was the thing that was being followed. So I think that's what the industry focused on. But I think now uh, with the new updates that are being done on AI system and for example this new interactive system Olisense, the Olympus one, I think it's going to be more and more adaptive to this. But nevertheless, I fully agree with you. I mean, if AI doesn't see it, it will not be able to point it out. So
Yeah.
I mean, it goes back to the same thing that we are talking about in the beginning, right? Slow down
Let me
and
see
do
if I.
not pull the scope too quickly. And we can see the pictures now.
Okay. So this is a patient that had done polypectomy, and if you see that this picture you see here, you see the scar, right?
Mhm.
Uh,
Right.
yes, and this result was a sessile serrated lesion without any dysplasia, and the patient came for control of something else. Was the bigger lesion in the left colon. So
Mhm.
if for me that the colleague, it was just 3 months, I think, or 4 months before those two colonoscopies. So this is the view you see. Something is here. Okay, but what is it exactly? So whatever you do, don't ask for cold snare and just put that sessile part and take it away and be happy that you have done a good job. So when I get closer to it, I could see that the sessile lesion, sessile serrated lesion component, and also this part was difficult. You see here at this part, this is a
Mm.
dark spot in the gland. You see that?
Mm.
Indicating that is a sessile serrated lesion, and this is the tubular lesion with the long capillary, what we call a fusiform capillary surrounding them.
Mm.
So this is a SSL turning to dysplasia. So
Mm.
this patient should be treated just completely different. Because
Hmm.
in that report was cold snap polypectomy in right colon here in CCOM. And you
Yeah.
see, this is when I put the acetic acid. You see, I was here. I showed you those pictures. But now we get back. You have the component of sessile serrated lesion far away there, and the
Mm.
scar is here. So
Yeah.
yeah, so to estimate the size of the lesion. So even here, when I look at it, I was wrong because I thought that the lesion start here, at the start, at the scar. But when I put the acetic acid on it, then I can see, oh, this part more distally to that part I was looking at.
Yeah.
It belongs to
Much
that
bigger.
lesion. Yeah, it's belongs to that
Yeah.
lesion.
Yeah. Yeah. Much bigger. Right.
So you can
Yeah.
see very
Hmm.
nice when you put the acetic acid on it and turn it to the NBI. Then you can see very, very nice.
Mm.
And of course, this was not an easy case because I had to deal with this car as well, with
The
the hot
fibrosis and
step.
everything.
Yes, exactly,
And
exactly.
the right colon and oh, must have been. This is a nightmare to deal with. I can imagine.
So
Uh,
that what I mean. Think about this the step two before you take the step one.
mm, right.
Okay?
Mm. This is fantastic pictures because I mean this is really exactly what I mean. Most of the time, most of the polyps will see they will not the SSLs they will not have that adenomatous component. But like I mean, seeing it makes you never forget it. I think, and really, I mean, it's important to start with seeing them and then choosing the right modality for that. So I really agree with you there.
And and
So
and
mhm,
maybe you're
yeah.
gonna mention about the acetic acid, what percent you need to use, etc., etc. So this is also important because should we dilute it or should we put it on it? There is a 5%, there is 12%, there is 1.5%. Which one should we use?
Yeah, in my practice, what I just buy the regular like acetic acid that you would use in salads, basically from the supermarket, and you
Yeah,
can just it's usually 5%
yeah,
standard stuff, the cooking stuff, and you just dilute it with saline. I usually do five ml of acetic acid with 15 ml of saline,
yeah.
and you will end up with about a 2%. But I think it's like up to 5%, you should not cause too much irritation because that's the thing that can happen. And I think it's a bigger problem if you're doing it in the upper GI compared to the lower GI tract. I think when you apply a little bit higher concentration in lower GI tract, the patient might get some abdominal pain, a little bit of diarrhea. But the upper GI tract can cause slightly more problems, especially if you're doing it in the esophagus. They might get some pain when they swallow, difficulty
Yeah,
swallowing, or some odinophagia,
yeah.
and
Uh,
you
uh,
don't want to do it to a patient is not well sedated because they may aspirate it and so
Yeah,
on. So
exact.
all of
I
these
mean,
things to keep in mind. Mm.
for your vision, for to see the lesion, everything from 1.5 to 3% is enough. I normally
Yeah.
I normally get them to between 2 to 3%, 2.5%, depending on
Yeah.
what bottle I get. As you said, if it's 5%, it's easier for nurse. I say half and half.
Mm.
If it's 12%, yeah, but everything from 1.5 to 3 is okay.
Yeah. Yeah.
And you can one
Um,
thing before I forget, once you see you talked about you suspect something because you see the mucus opposite side of the liquid is there in the right colon. But be careful. I normally when I don't see the very obvious the SSL, so I don't wash away all mucus because then maybe I have difficulty to find it. Of course, I can put the acetic acid, but what I do I keep some mucosa on it just to recognize it again. Put my acetic acid, the first one, to make sure that I
mhm.
have something that give me the sign that here I am. Then I wash that part I want to exam with the mucus, wash it and put the acetic acid again. So
Right. Right.
don't lose it because it's easy to lose that.
Yeah. So this is and like SSLs really like is something that you think you would just like speak about quickly and then you'd be done with it. But there's so much to talk about here because just of their importance and their biological activity if they become dysplastic. So I think it's very important that we really focus on that. So I think because we're like today, we thought about talking mostly about the optical diagnosis and these classification systems that we can touch upon. I thought maybe we can talk for next few minutes about uh, adenomas, which are way more familiar to most people, and your thought process when you see an adenoma. And I'm thinking about just like the basics here, uh, because I think in the next episode we're gonna start discussing polypectomy specifically, and I think once we start discussing the strategy of polypectomy, we will be talking in detail about that optical diagnosis and how you basically break down the polyp by reading it carefully into basically a risk for colorectal cancer in percentage.
Yeah, yeah,
So, so maybe if we can just touch upon like adenomas and how we look at them and classify in your thought process. And I think that we can in today's episode on that because then we have discussed the things that are most important and then we go
of
to the
course.
next step next
Uh,
in the next episode in
yeah,
polypectomy.
to make it very very simple, I mean, uh, the the lesion, just regarding the lesion at overall. So and before I think about removing, etc. So I think you should be familiar also with SMSA. Uh, I think people are endoscopies nowadays. They are, and you can regard depending on the size, morphology, site, and assessment, then decide if you are capable to remove it or you send it again. That's one thing I have in my mind, but regularly with a lesion that is not very big or advanced, etc. So when I see that, okay, this is not a sessile serrated lesion, this is adenoma, then I have to decide, I have to assess what in the mucosa and also submucosa, what relation does this lesion has? Is it only the
Mm,
mucosal lesion, which is
mm,
T0, or it may go a little bit down. And first of all, we know that the small lesion, less than 1 centimeter, they have a very very low risk of invasive to the submucosa. But
right.
I look at when but to make sure I try to distinguish, is it low grade dysplasia or it might be high grade, and then the border to the early T1 cancer, it's not always so easy to distinguish. So what I do, I turn to the I look at the lesion, I take my picture with the distance, etc. We're not touching that, but when I get close to the lesion, I put on the narrow banding, and
Mm,
the first thing I want to examine is the vessels pattern. I look at the vessels
mm,
pattern, and
mm,
everyone knows about the nice GNet, etc. If the vessel pattern are very regular, for instance, I can show you that I mean everyone know that the nice. So let's see here if I can I share with you here. So I actually you see my picture.
mm,
Uh, the Sino classification was the one who came before the NICE. So that's only based of the vessels. You see here, this is the regular vessel pattern you see here. The same size of the vessel diameter, and the shape is very regular, homogeneous. You agree, right? So for me, is the very, very benign lesion, low-grade dysplasia. So those cases, I don't need to put any dye on it, etc. When I see the vessels are very, very regular. But once the vessels is not regular and the diameter is different in that area I'm looking at, so I may suspect that maybe it's more than low-grade dysplasia. Then for me,
Mm.
it's the gland pattern is also very important.
Yeah.
Is it
Yeah.
regular gland or not? Then we are coming to all those the Kudu classification and also nice classification, touch that, etc. So answering your question, I look at the vessel first. Is it regular? And also you can see here that the gland, which are the whitish part, they are also very regular.
Right.
So then I'm happy with my narrow banding. I don't do anything extra then. But once I
Yeah.
see the vessels are irregular, the diameter is different, etc. Then I put something else. If I have an
Yeah.
E set is maybe I'm happy with that. Otherwise, I put a dye on it and try to see the gland. How is the gland?
Mm.
And then we're coming to a Kudo classification, of course.
Right. Right. Really, really helpful. Like, so I actually do the same thing where I look quite often at the bezel. Like, when I see a polyp, I look quickly in white light, then I shift to MBI, preferably with near focus as soon as possible to look at the bezels. And sometimes, like, trying to use a lot of water to basically drown it in water to just get that natural like enhancement, just to get a better view of the image, to actually be able to make a quick optical assessment, and then I would switch to white light and I would be looking at the surface. So I think this is a really good framework for people to remember. Is like, you have the surface and you have the vessel pattern. So you're looking at the surface. What does it look like? Is it regular, irregular? And you look at the vessels also. Are they regular or are they irregular? Can you follow them? Can you not? I think this is something that can cause some confusion sometimes, because quite often a polyp is not homogeneously irregular. If it's cancerous, quite often there's a bunch of areas in it that look pretty regular. And there's that one little area that is irregular, or that has basically absent vessels or amorphous vessels, or totally disturbed there. And I think one thing that people that should look into is try to visualize the whole lesion, right? Not just not just like, don't focus on one part. Visualize the whole lesion and try to look at the part that looks the weirdest or the worst, because I think this is where your optical assessment would this is where you would win the buck. This is where you would actually get the best value for your money, so to speak. Uh, because you may say that this lesion looks regular, but and then you start chopping at it. You see that while after removing one or two pieces, you will see naturally that part that you were not looking at before that looks slightly more irregular, right? Uh, or maybe you start you just miss it altogether, and then you end up removing a lesion that ends up being a T1 that should have been done in a different way. Um, so I think this is where learning the classifications slightly well, I think. And I think one thing that can help is having those classifications on the walls in your unit, or in your room, in your endoscopy room. So this is what I've done in my unit as well, because I teach a lot, and quite often I need to show people what I mean
Yeah.
on the wall. So I have, like, the whole wall is basically full of posters that I've printed and laminated of different lesions that we found in our unit, and like something from publications, and always like talk about them. So look at this compared to that, and this is why we think that this lesion contains maybe cancerous cells, or this is why it doesn't. I think that would help people to get better at learning, basically teaching that muscle memory, right?
Absolutely. And also, all these classifications, um, you try to memorize everything, but you are a human being. What was
Mm,
that? JNet to be high or low, or JNet to be
mm,
so it's very nice. I have also all those on the wall, in the
mm,
room, on site in the
yeah.
room. Sometimes I
Mm,
need, I'm not completely sure. I look at the picture. Oh, that's it. Because I have seen people have it in their office. Then they go
mm,
back and they try to remember how did the polyp look like compared with the picture. Have it in the room. It helps you. But what I think that, yes, I think you mentioned that as well. When you see the picture, that's why the recommendations of how to take a photo is the way it is, because they wanted you to make sure that you have seen the lesion from the distance, the whole entire lesion, because then it can wake up something for you. That what you call it, blink. Sorry. And that's okay. This is ugly. This is not a regular one. If you look at these pictures, for instance, so all of these are cancers. All of these are
mm,
cancers. But I mean, if you don't look at the whole lesion, you just go to this lateral site, and look
yeah.
at the very nice with the NBI close to it. This is low grade dysplasia. But
Mm,
as you said, you have to see the whole entire lesion, see all those eventually sign of cancers, demarcation lines, reddish, etc., etc.
mm,
So this is a very, very important point that you touched that. That look at the whole lesion and then break it down piece by piece, millimeter by
mm.
millimeter, and make your decision.
Very good. Yeah, I fully agree with you. Maybe if you end your screen sharing now, please,
Okay,
Morteza.
I stop sharing.
Uh, yeah. If you
Okay.
stop sharing this, because this is I think this is great, because I mean, last thing that I would say about this, and I think you've covered it really well, and I think in the next episode we're going to be diving really deeply into how to break down these lesions, like little by and get some videos together, and doing the optical diagnosis, and then choosing the right strategy for resection, so that anybody who's watching can actually follow this time, like just pause and write down what they think it is, and then see if their the guess was correct, or not, because I think that something can be helpful. One thing that the ESGE has implemented now is so-called SODA, or classification of SODA, like framework, or simple optical diagnosis. Accuracy has been around since 2022, which basically gives you a framework about like how good you should be at your optical diagnosis if you're going to actually start implementing the new guidelines of, like, whether you can leave a polyp in situ, or whether you can resect it and discard it. And you need to reach this kind of 80% sensitivity and 80 to 90% specificity for identifying neoplasia if you're actually going to start doing this in your practice. So I think anybody who's doing this and still training, I think it would be really beneficial to monitor every polyp they remove. Like when they remove it, send it for histopathology, just write it down what their optical diagnosis with, and then match it with the histopathology. And after like doing like 50, 100 of those polyps, you will definitely see where you are actually making mistakes the most. So I remember me personally, when I and you told me back then to start doing this, found out that I was misjudging right colonic adenomas as SSLs. most often. Otherwise, the rest of the colon was fine. And then I started looking at the pictures of these polyps and started seeing the pattern that the mistake was the same every single time. It was the angle from which I was looking at, and it was like not using enough BI, not using the near focus, and not like using the, all the functions that I had on the scope, and with time it just becomes better and better. And I mean, but even today, like sometimes, I mean, I need to pick up the phone while I'm scoping and show you or another one of my friends who are good at this. It's like, what the hell am I looking at? And I think there's no prestige in that. I think everybody should be should have the humility to do this, because these decisions can have some severe consequences for our patients. So
So I
I
agree with you.
appreciate
And,
it.
if I want to give one advance to young generation endoscopies or trainee, that just go step by step. Optical diagnostic comes before treatment, of course.
Mhm.
Good intubation technique comes before detecting and assessment. So go step by step. Be very good at one step, then go to, because once you get into the next step, there is a huge of stuff you have to learn, both theoretical and practically. Then it's
Right.
difficult go back and learn again that part you have missed. So before you be good at polypectomy, to be good at optimal diagnostic, optical diagnostic.
Yeah. 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 Perfect. Morteza, this is great. We could talk about this for hours with you, you know that, but that's why we decided to break this down into multiple episodes, so that we can explain this in and hopefully it's gonna fit in 3 episodes. I hope, but we'll see how
We'll
it
see.
goes. Perfect, Morteza. Thank you so much for your time today. I really appreciate it as always. And we will be speaking again soon.
And thank you very much, Summer. You are doing very well, very good job, and I'm very happy to be part of it. It was my pleasure to be part of it.
Thank you so much,
Thank
Morteza.
you.
All right.
Thank you.
Have a wonderful rest of your weekend.
All right.
See you. Bye bye.
Bye bye.